Welcome to myEyeAcademy.com. I'm Professor Mahfouz Hussain from Pakistan. MyEyeAcademy.com is a platform for ophthalmic teaching, particularly for undergraduates and paramedics. In this lecture, VHB Chapter 7, Section 3 will discuss the corneal ectasias, and the prime example of corneal ectasias is keratoconus. The plan of the talk is we will first classify ectasias, then we'll take up the keratoconus as a prime example, then symptom and signs of keratoconus, investigations and treatment of keratoconus. First of all, how to classify corneal ectasias. Corneal ectasias can be because of inflammation or because of congenital eye diseases. In the inflammatory ones are ectatic cicatrix, which is bulging of the cornea in spite of normal anterior intraocular pressure, and what happens that the ulcer makes cornea so thin that it bulges in spite of normal intraocular pressure. Second ectasia because of inflammation is anterior staphyloma, which is bulging of the cornea that you can see here. The cornea is bulged out, and that is because of thinning and increased intraocular pressure. So in staphyloma, usually the intraocular pressure is high, while in ectasia cicatrix, the intraocular pressure is normal. Then comes the main topic, which is congenital ectasias. And now we have come to the main group, which is congenital ectasias. One of the congenital ectasia is keratoglobus, in which if this is the cornea, then the cornea bulges as a whole, and it is called keratoglobus. It's not a very common condition. Another example is pellucid marginal degeneration. Look at the cornea is bulging inferiorly. So if this is the cornea, it bulges inferiorly like this with the inferior belly, and we call it pellucid marginal degeneration. The most common one is keratoconus, in which the cornea protrudes like a cone, and we call it keratoconus. From now onward, we'll be only talking about the keratoconus, which is the most common type of ectasia. Etiology of keratoconus. This defective collagen tissue in the cornea, which causes weakness of the corneal stroma. As a result, cornea bulges out. It may occur with ocular anomalies like blue sclera, ectopia lensa, Down syndrome, and Marfan syndrome. Remember, all these are MCQs, so do remember these names, please. And now the general features of keratoconus. It's a progressive disease, which means the ectasia keep progressing if you don't halt it. It may be either central or paracentral part of the cornea which is involved. Usually the patient presents in teens or 20s. It's a bilateral condition, but one eye is followed by the other. It's mostly without other diseases. Now remember systemic and ocular associations. Systemic associations are Down syndrome, Marfan syndrome, and Ehlers-Danlos syndrome, while the ocular associations are vernal keratoconjunctivitis, blue sclera, retinitis pigmentosa, and aniridia. Symptoms of the keratoconus. Because the cornea is ectatic, so the visual acuity is less than normal. Usually the patient is myopic, but the myopia is unstable and progressive because of the progressive nature of disease. Astigmatism is irregular and changing, so it's difficult to correct with the glasses, and the patient frequently changes glasses because of the unstable refraction. Signs of the keratoconus are conical shape. Look at the shape of the cornea, it's conical, so shape of the cornea is visible in advanced cases, which is a very easy sign to pick. Then is the Munson sign. When you tell the patient to look down, there's a bulge in the inferior lid, and that bulge is called Munson sign. On a slit lamp, you can see vertical lines, which are called Wart's lines, or the Fleischer ring, which is subepithelial or you can see the scarring in the center of the cornea, which is because of the eye drops, and that we'll discuss in the complications. So these are the signs which you can see clinically. Then the complications of the keratoconus. One is the acute eye drops, and second is the central scarring, which is because of the eye drops. What is eye drops? Because of the increased pressure and thinning of the cornea, the descending membrane ruptures and the fluid enters into the stroma. It's very painful, and the treatment is to reduce the intraocular pressure and give hyperosmotic topical drops to extract the water out of the cornea. This can lead to the central scarring because of the repeated episodes of eye drops, and that needs further attention. Keratoconus investigations can be done with different gadgets. The common ones are direct ophthalmoscope, with the help of which you can see a teardrop sign, and with the retinoscope you can see the irregular astigmatism, and scissor reflex, in which the reflexes close from one side to the other like scissors. Then you can use the keratometer, in which the keratometric reading is coming more than 47 diopters. That's a very good indication that the patient may have keratoconus. And then a definite diagnosis can be made with a corneal topography, which can measure the corneal thickness and the corneal bulge in different ways and can give you a very good idea whether the patient has got keratoconus or not. Then is the treatment of the keratoconus. Early keratoconus can be treated with the glasses. If the glasses don't work, you can use the hard contact lens or the rigid contact lens, which you can see here. Another very good option is collagen cross-linking, in which you use B2 or riboflavin eye drops. You install the riboflavin eye drops and then expose the eye to the ultraviolet rays, and that makes the cross-linking between the collagen fibers of the stroma and makes the cornea more strong and resistible to the bulging. Another option for the advanced keratoconus is intrastromal corneal rings. You can see a ring here, and this ring you insert it into the stroma, and that changes the shape of the eye and patient is able to see better. Penetrating keratoplasty is another option. You remove all the 5 layers of the cornea and replace them with the donor's 5 layers. You can watch the video in section VHB 18.8, and you can also see it in a keratoplasty section. Another option, and a very good option and the latest option for the surgery, is the DALK, which is deep anterior lamellar keratoplasty. Here, instead of all the 5 layers, you only take the top 3 layers and replace them in the patient. You can see that in the video VHB 18.9. Please do subscribe and press the bell button to get the notifications for upcoming videos. Thank you very much for being with me. Thank you.